Will GLP-1s ease or escalate healthcare costs? Which is a question that all of us are asking, and I think some of the people on this call can help to give you some answers. I'm Alexis Kaiser, healthcare editor at Newsweek, and I'll be your moderator for today's discussion. We're so excited to kick off this webinar, which is one in a series of Newsweek healthcare webinars running throughout the year. My colleague will drop a few links into the chat if you'd like to register for our next events in July. And to make sure that you don't miss any updates, you can subscribe to my weekly Access Health newsletter. My teammate will also drop a registration link in the chat for that. A few quick housekeeping notes before we get started. Our audience is made up of healthcare professionals and decision makers, and our focus is on insights that speak to the complexities of the industry. So we want to make sure this is a productive conversation, and our comment section is moderated. But throughout the discussion, please put any questions, personal experiences, comments that you have in the chat, and I'll raise relevant ones throughout the discussion. We'll take about 10 to 15 minutes at the end too to address questions more deliberately. And with that, let's go ahead and dive in. I'd love to introduce our esteemed panelists, Robert Deshays, Chief Operating Officer of Benefits at WEX, Kevin Hearn, Senior Vice President of Lilly Employer for Lilly USA, and Dr. Lydia Alexander, Chief Medical Officer of Anara Health and the immediate past president of the Obesity Medicine Association. Thank you all for being here. Robert, let's start with you. You're working directly with employers that are trying to balance employee demand for GLP-1s against rapidly rising healthcare costs. What are the most common concerns that you're hearing from CFOs and benefits leaders today? And how are those concerns shaping coverage decisions for these therapies?
Yeah, Alexis, a great question. It's a conversation we're having almost daily. It's got such a groundswell around these GLPs and the excitement around what they potentially can offer. And so as employers and primarily CFO and benefit leaders are really looking at this in a very deep way of how they can manage the rising costs of not only their health plans, but also as you think about these high demand medications that are actually changing the game. And you're getting a rapid adoption by millions. I mean, just in the GLP-1s, you're looking at 1 in 8 Americans today trying the GLPs or using the GLPs, and there's 34 million Americans with that are classified under weight management candidates, and that number is, I think, probably pretty low. And then when you consider all the additional benefits of GLP-1s, it really is driving a lot of demand from employees back to their employers to have coverage. So there are a number of things that they're concerned with, and I would just boil it down to one is how do you manage costs against a basically a health plan system that's back from the 90s. Then you have the ability to programatize an offering that will allow you to actually manage it predictably. And then having a system that can scale and allow you to actually provide a great experience to your employees and to your employees as they're participating in such programs. And with costs ranging from 900 to 1500, and even subsidized by the pharmaceutical manufacturers, at 500 a month, those are some fairly significant cost additions for both the employer as well as the employee. Managing through that, we're seeing that as healthcare costs increase, you've got employees having to make trade-off decisions between what they pay for, discretionary funding, et cetera, for themselves. And then you have employers on the other side trying to figure out how they can make this benefit available because they know it's important to have healthier employees. There's better productivity, efficiency, et cetera. And so what we're doing, because WEX is a true enterprise platform, we have part of our capabilities a health reimbursement capability that allows arrangements. They're called health reimbursement arrangements they give us the ability to actually work with an employer to develop a program that gives very clear definition around the aspects of that program. You can define a number of factors so that you can put the qualifications in place and then manage the ability to then put a defined contribution benefit to them. And it will allow them to have a very predictable monthly, quarterly, basically benefit that they will know they can spend, they can control costs, and have predictability. So I'll pause there. I know we'll have a lot more questions down the road, and I don't want to take up too much time.
Absolutely. Thank you, Robert. And that customization is something that I know more benefits providers are looking to give to employers as they navigate, as you said, all of the unpredictability around GLP-1 therapies right now. Kevin, I know Lilly has also spent the last several years building direct relationships with employers around obesity treatments like GLP-1s. What has surprised you most about how employers evaluate the value proposition of GLP-1s compared with how Lilly initially expected them to?
Yeah, thanks for the question. Maybe just to kind of level set big picture, we're a medicine company that brings innovative medicines to address unmet medical needs, and really excited to launch in obesity. But I think we learned early on as we began talking to employers in the months leading up to Zepbound launch, access to medication is kind of the second half of the journey. You deliver it to the market, you've got to make sure patients have access. And this is a unique class where employers are not, it's not automatically part of the standard formulary. And so I think, that's been a challenge and a journey for us to think about how do we pair innovation from an access perspective as well. And so you saw us launch Lilly Direct as a way to solve that problem one patient at a time for folks in Medicare or employer-sponsored insurance who didn't have access. We're excited with the July 1st launch of the Bridge program. So a lot of Medicare patients, tens of millions of patients will have access to those medicines. And, as we've, over the last year, we've kind of seen stagnation with employer-sponsored insurance. Right around maybe half of employee lives in America are covered. And so we've continued to innovate by introducing our Lilly Employer Connect platform. And really our goal is we want to get that number from half of employees in America with employer-sponsored insurance, up much higher. We want that to be 2/3 then 3/4, 90%. Until everybody has access. And that's something in other disease states we're in, type 2 diabetes, oncology, immunology, that tends to happen within the 6 to 12 months after launch. In terms of surprises, maybe not surprise, just an evolution. I think when we were talking to employers in late 23 ahead of the launch of Zepbound, just getting a lot of questions around, is obesity a chronic disease? Is this something we should be paying for? There's supply chain challenges, a lot of other clinical questions. How do they work? We're concerned about some of the tolerability issues. I think if you fast forward now over the last 2.5 years, the evolution we're seeing when we talk to employers, I think almost everyone, probably either personally or someone in their life, they've seen someone's lives profoundly changed by an obesity management medication. And so we're really spending our time not talking about like the clinical outcomes and whether this is a disease and all of the good it can do preventing over 200 comorbidities downstream, but really like how do we pay for this? Because this was in 2021, all employers had a zero in their annual pharmacy budget for obesity management. Maybe they had a few generic scripts, but they just weren't spending. And so, other large drug spends in immunology and oncology, when Skyrizi comes into the market or Dupixent comes into the market, it grows the class, but it also cannibalizes last generation technology. And so the challenge with this class is great clinical outcomes for a large percent of the population, but you're growing from zero. And really kind of some of the downstream benefits beyond the clinical outcomes are medical trend offsets and workforce productivity that you're going to see multiple years down the road. And so I think just seeing that evolution from focusing on clinical outcomes to more, hey, how does this impact medical trend and when are we going to see it? And how, like, I believe in this, how can I afford it? Has been a really, interesting evolution, I think, over the last couple of years.
Certainly. Thank you, Kevin. It is interesting to hear about that shift in belief in the clinical evidence as we get more support, more studies, and more proof that these therapies work for a wide variety of chronic conditions. And we're fortunate to have one of the most prominent physicians in the space on the call. Dr. Alexander, I would love to turn to you next. I know that you've argued that obesity should be treated as a chronic disease rather than a lifestyle issue or a shortcoming. How does that framing change the conversation around whether GLP-1s are a cost center or a long-term investment?
The honest answer, Alexis, is that they're actually both. And it's important that we recognize that, accept it, and also understand that we're underestimating the amount of time that will stay at a cost center while underestimating the long-term investment in health. As Kevin mentioned, obesity is the disease of diseases. And we're already paying for it. Obesity drives at least 250 different conditions. The most common ones, the top 10 that we see in primary care and elsewhere that are the largest cost centers in the US economy, it can all be treated by treating obesity as the disease of diseases. And so we're underestimating the cost of doing nothing, which is not zero. Not covering GLP-1s is not a neutral financial position either. It's a decision to defer and compound these different diseases. Type 2 diabetes, 85 to 90% of individuals have obesity. Kidney, liver diseases, cardiovascular disease, obstructive sleep apnea, all of these diseases, greater than 75% of individuals have overweight or obesity. So whether we acknowledge that or not, the chronic care, the sick care it is what our U.S. healthcare system has been treating. And to move to a healthcare environment, this is a once in a lifetime generational opportunity that requires leadership and not reaction, that we embrace these medications and think about what the downstream benefits are, how we can reverse disease and create a healthier population. And so that's really how I think about treating obesity. It's not that we're just treating obesity; it's what we're treating and reversing as a result of treating adiposopathy or the inflammatory condition in the human body.
Great. Okay. And all of you have mentioned this tension between the downstream positive effects that we hope will reduce healthcare spending in the future and the current costs, which are overwhelming to both employers and to individual consumers. What time horizon are you all seeing healthcare leaders use when evaluating the ROI on GLP-1s? And do you consider that time horizon realistic?
I'm happy to.
Yeah.
Well, first of all, I mean, everybody's already paying a lot for obesity. So there's almost $500 billion a year in direct medical costs for obesity and all of the obesity related complications downstream, and over $1 trillion more of lost, workforce productivity. I think the challenge is that time horizon, is that you've got benefit leaders who are judged on kind of an annual budget cycle and trying to constrain to pharmacy spend. One of the things we've done at Lilly, from a benefit standpoint, is we look at it in terms of this is an investment from whole employee, entire comp and ben, our entire merit portfolio. And at that point, it's less than 0.5%. And so we feel this is a foundational class that will have significant ramifications across a large part of our workforce. And so some of it is your perspective probably that impacts that time horizon. But I think most recognize they're not going to see medical cost impacts in the first year or two, but we certainly will. And I think Dr. Alexander said it well. You're probably, we're probably underestimating the impact that we'll see down the road. And I'm very encouraged by some of the things we're seeing. Aon's got a study that's out, Flight, with the state of Connecticut and Milliman. We look every 6 months at, tens of millions of claims data, and you're already seeing in the highest cost claimants that have maybe the most comorbid number of comorbid conditions with obesity, meaningful changes in their medical cost trend at 12 and 18 months. We just think that data needs to mature. We've solved a lot of problems at Lilly, innovatively, but we can't figure out how to get 4 and 5 year real world evidence 2 years into launch. So some of this requires patience, but that's really challenging for an employer that is feeling the significance of the growing spend, and not having the hard real world evidence in their pocket to kind of show the math to their C-suite to let them know, hey, this is going to pay off in the long run. And we need to continue to develop that evidence and bring it to market each year.
Well, I would argue that some of the evidence is already here if we connect certain dots within the U.S. economy, and also looking at the GLP-1 medications. The SURMOUNT-1 extension study, which is a 3-year study looking at prediabetes, is, I think, an excellent proxy for what the return on investment is. When we think about treating or preventing one case of type 2 diabetes, the gold standard is the diabetes prevention program. And that showed after 3 years, 2.8 years, a 58% risk reduction in individuals not progressing to type 2 diabetes, which is a huge cost savings for the US economy and for individual employers, big, medium, and small. When we think about the SURMOUNT-1 extension study, the information there shows a 93% pooled risk reduction in type 2 and preventing type 2 diabetes. That is earth-shattering. 58% for the gold standard and 93% for the SURMOUNT-1 extension study. And that was also a 3-year study, a 3.5-year study. We think about the expense of the medications and say, well, DPP is far less expensive. And so the quality adjusted life years, where we try to reach 100 to 150,000 quality adjusted life years as sort of the metric where something becomes affordable or cost effective. And those are two different things. Cost effective, we've proven as part of the ICER report in 2021. Affordability is scarier because that's a shorter term. If there's a run on utilization, we could go broke, and we worry about that. Medicare is probably worrying about that right now with the bridge program starting July 1st. But when we consider the cost of not doing anything, when we, anytime that we prevent one case of type 2 diabetes, in 3 years, we save somewhere between $60,000 and $20,000. And we see that because every new case of diabetes in year 1 costs between $6,500 and $8,000 to treat that year. It becomes less expensive in year 2. The price goes up again in year 3. There are various studies that have shown this, but the average cost, even if we look at the low ball, is $16,500, and that's excess healthcare costs, excess, not total. So when we think of it from that standpoint, and we think of it from QALYs, and the price of orforglipron or Fundeo, which has gone down to $5 or $10 per day. So that's $2,500 in a year, as opposed to $6,000 for a mid-dose of Zepbound in this moment. We're talking about some economics that actually work at a population level. And this weekend at the American Diabetes Association, the Attain Maintain study was published, and there's another study that's coming, and another Maintain study that's coming out from Lilly that shows that we can de-escalate treatment from the more expensive medication, which is either Wegovy or Zepbound, to Fundeo, and we have 75% of the weight benefits stay. So when we think about obesity as the disease of diseases, and that 85 to 90% of individuals who have type 2 diabetes also have obesity or overweight, we're really changing the economics by treating just type 2 diabetes. And I'll also mention that type 2 diabetes, 38% of the country, so 1 out of 3 individuals has prediabetes. Many of us don't know it. And so statistically, that means that one of us in this room and during this interview has prediabetes and may or may not know it. And so this is not a small problem. This is a very expensive problem that we're kicking down the road when we're not treating it with these medications, which as was said by one of the speakers, are really foundational and have the ability to change the entire healthcare economics discussion on a nationwide population level way.
Yeah, I would just add, I mean, you can hear that there is a growing set of evidence that shows the benefits here. And what it all comes down to is, how employers can actually put a model in place. They're struggling today with health plan, health plans that were developed back in the 90s, and they're very open-ended and they're high cost. Anytime you need to add another medication in, especially when you think about these high velocity therapies that are having great impact in the in our population, it creates a very, very big financial problem. And so what we're hoping is going to happen through here is that through the use of a defined contribution, using a health reimbursement arrangement as an example, you take it outside of that open-ended plan structure, and you create a much more predictable, planned way of managing this forward. So you're making things more cost effective for an employer, but you're also making it cost effective for an employee, where you have a set amount every month, every quarter. You know what that expenditure is going to be. You don't have any surprises on either end, and it allows the employer to actually manage those costs without affecting the medical plan as it stands today, while offering new therapies through a new defined contribution. And that's a technology that we can actually employ today so that we can start to overcome this financial challenge immediately. WEX, I can tell you today, we work with 60% of the Fortune 1000, and through our conversations with them, as we're introducing this as an option for them, the adoption rate is very positive right now. We have several pilots in program right now for our technology. We at WEX are employing and deploying it ourselves in July. So we're very excited about making that offering to our employees and making this benefit available, because we know its importance. So as we're doing this, I think the success is going to be us working with, those CFOs and those benefit administrators to help them realize that this is a benefit that they need to make sure is available, and that they can make it available in a very reasonable way, predictable way, and cost-effective way.
And I think this is a very important point that Robert makes, and the need, the existing need and the pain point to operationalize how we manage and roll out life-saving medications like this, that are not niche medications, are again, from a large world perspective, can really change the fabric of society. And we can do it well if we do it in a way where we're taking into account the operational aspects of it, and how to move a healthcare system that, as Robert mentioned, is in the 90s. We need help with that, and we need management of benefits in a responsible way that is also going to confer healthcare to rather than sick care to those populations.
Go ahead.
I was going to say you're on mute, but I did want to just say, just a couple quick facts I wanted to add into the conversation is the Employee Benefits Research Institute, which does a lot of work here. 74% of the polled want benefits like this, and they find it to be one of the most valuable things a company can offer. 43% drop out because of costs. And so it's the importance of operationalizing could not be more important to really, have the impact that we could have by working together with the health plans, and our ability to operationalize this with the manufacturers and with the providers, et cetera. So we're really looking forward to this opportunity to change the healthcare game as we move forward.
Thanks, everyone. Robert, you mentioned that this is something employees really want. How should executives think about employee retention and productivity when evaluating these therapies? Is this going to become an expectation? And how soon, if not already, do you expect that to be something that employees want to see in their lineup?
Yes, we're already finding that employees have an expectation around this type of benefit. They are, so you look across the generational gap, you would think that, hey, the younger people wouldn't be, the younger generations, you think millennials and Zs wouldn't be as concerned. actually, it's just the opposite. While you have our boomers still out there and our Xers, there is as much interest, if not more interest, in the younger generational employees today that are actually looking at this. It's a high demand. You're looking at 70+% of the employees are expecting to have access and a benefit with their employer, and they find this to be a more important benefit than overall pay sometimes. So they will actually take less in their base salaries to have a better benefit set of, better benefit package. And part of that is these new therapies that come into market that have a great impact on health, metabolics, et cetera. And those are things that they have a high interest in. So we're already seeing the effect and we're already seeing the demand. Now it's a matter of us really actioning and operationalizing this with employers so that we can actually bring this to life.
Thank you. Kevin, I'm curious. Lilly has created so many breakthrough drugs over the course of its history, and oftentimes we hear that GLP-1s are unprecedented, and indeed they are in obesity and weight loss. But I'm curious if there are lessons we can learn from previous breakthrough therapies in preventative medicine when it comes to evaluating GLP-1 adoption.
Yeah, I mean, I think, if you look at like statins, for instance, I think one of the things we're most excited about, both Wegovy and, both Novo and Lilly have launched oral GLP-1 medications this year. And, there's, probably 20 to 25% of the population is needle phobic. If you think about treating something on a global scale, there's just a lot of countries in the world that don't have a cold chain to support a parenteral injectable product. And so when we think about impacting the globe, from this disease, having an easy to take oral pill is foundational. I think for statins, you see that's just become, probably a part of routine prevention for everyone, and really, oral distribution becomes a great way to scale to the masses. And so I think we're really excited to see how that complements the injectable medicines that are already here. And there's more innovation coming. And so I think you can look back and see that, a simple, easy to use pill can really have a tremendous impact, because one of the biggest challenges you have in medicine is once you get access for folks is driving adherence, and we know just in any chronic disease, adherence is about 60 to 80% in a year, just in general. And so that's something that everyone across the healthcare ecosystem is, how do we drive better adherence? A simple, easy to use pill is great. If you think about, Medicare with this product, the Bridge program going live on July 1st, most of the folks in that age group are probably already taking other medicines. This is just another pill to put in their pack for their daily regimen. So I think that's something that we're excited to see, and I think Dr. Alexander talked about some of the exciting ability to, follow, maintain, follow an injectable with an oral for maintenance, and some of the, exciting durability we've seen of effect there.
Absolutely. Dr. Alexander, what are we seeing in the literature and in the patient population when it comes to adherence to GLP-1 therapies?
Well, I think what we're seeing and we're going to continue to see is that adherence really is, or it depends on the environment in which a patient is being treated. Right now, we have a fragmented system, and really two larger players. There's either the prescribers, which would be the online, what I call online prescription mills, and that are providing these medications, but are not really providing wraparound comprehensive obesity care. And we can't expect with that type of prescribing that we're going to see long-term adherence. And so we will not then see the benefits of the medications downstream, because there are really two aspects to treating obesity. The first part, which we spend a lot of time thinking about as a society, is the weight reduction part. This is short term. This is 6 to 9 months. months, at some point we reach some type of goal weight, either for health or for our personal or personal preference, and that sustaining that weight for a long term, that's the area under the curve that matters for health. It matters for a variety of different reasons, and so comprehensive obesity care within the medical care setting is really what's going to be driving that type of long-term adherence with the downstream benefits. If we're just getting prescriptions online, and I was able to go to one of the top online prescribers and within 7 minutes get a medication, I'm not sure I should be saying that here, and because I falsified information. Now that's wrong, and that's not great care. And if I were to be a consumer who does that, I may also not understand that when I stop that medication, I'm not going to get the downstream benefits, just like any other medication that I may be using. If I don't take my blood pressure medication, I can't expect my blood pressure to be doing well. If I don't take my thyroid medication, my thyroid numbers will come back elevated. And so we need a responsible comprehensive obesity care coverage. And we need to do that again within the medical care setting. We need to do it in a way that's affordable. And the way to do that is for everybody to work at the top of their license, for a physician, advanced practice practitioners, for lifestyle coaches, and also telemedicine care, which is different than telehealth. So telemedicine care are video visits that extend into the population and decrease costs of care. So there are many ways that we can get there in a responsible way. Adherence is going to be the big driver there for adherence.
Okay. And talking about that comprehensive coverage, it becomes clear that this isn't just a medication that insurers and employers are going to have to pay for. There's additional supports that are needed. Robert, how is that wraparound care and the cost required to sustain it influencing the way that employers are thinking about GLP-1 coverage, if at all?
So they're definitely thinking about it. It's a great question. What we're finding is those that are actually looking at alternative ways, so going beyond the open-ended, traditional health plan and looking at new ways, like the health reimbursement arrangement that I mentioned earlier. As they're looking at this, they're looking at a few things that are very important. One is, can they put a program in place that will actually promote adherence? And so it's not just about the benefit, defined benefit, but it's also about the behavioral aspect and really connecting across that experience. So, so you take the financial piece along with the adherence and the behavioral, so that you can really have long-term benefits. And that's one of the things that if you're a CFO or a CHRO, you're really looking at, these benefits as investments in your employees. You want to be able to see that you are helping improve and that it's an overall benefit for the business, but also for your employees, because they are your most important part of your company. I mean, that's when it boils all down, you want healthy, happy employees. And by offering benefits such as this, you put them in a position to, by using these alternative alternative technologies like health reimbursement arrangements, you put something in place that's, as I mentioned earlier, highly predictable, planful. You connect that with a program that really promotes longevity of that program, and you then get to see the long-term benefits and the return for the company. So, and another thing that's super important here is, according to EBRI, so the benefits that I mentioned earlier, Research Institute, they find that 51% of employees don't even know they have the benefit. That's a pretty staggering, when you think about it. You figure most people know what their benefits are, even around these therapies that have, really gone viral in a lot of ways. They don't even understand that they have benefit themselves. And so communication along with that program is going to be vital. So, I would be looking at things like, adherence and longevity of participants, as well as the level and quality of communications that a company is giving to promote those things in combination with the financial aspects of a health reimbursement arrangement.
And I would add to that one of the most sort of important healthcare costs that we don't think about are the indirect costs. And so with many of the employers, because about half the country, or 45% of the country, has government insurance, the other portion of it has employer-sponsored healthcare insurance. Very few people go directly to an insurance company to get their insurance. And so employers should be thinking about not only the direct cost of that healthcare, but they should also be thinking about the indirect costs of having poor health for their workforce. And so this includes absenteeism, presenteeism, which is actually very costly and underappreciated, disability. So people go on disability, early retirement, and pensions that are paid out as a result of that. And so there is a very large, when we throw in indirect costs and the importance of having benefits management and understanding what your benefits are, taking advantage of them, we're actually creating a healthier workforce. And employer-sponsored programs, which again are the majority of programs that are not government, should really care about those indirect costs too, which do impact their bottom line, and also make a case for why these medications, which again, as Kevin had said, 250 different conditions, the top 10 certainly are included in all of this, including cancer. And there are 13 different types of cancer that are directly related to overweight and obesity. And so when we look at all these different drivers, we're going to see that adding indirect to direct costs in terms of the cost effectiveness, affordability, and what equality looks like, we're definitely going to be hitting the correct mark there, which makes these medications feasible with correct management.
Okay, that's a really fascinating point about the indirect costs and how they can affect employers in real time. I am curious to hear from you all. According to PeoplePath, the average time that an employee stays with a company in the United States is 3.9 to 4.2 years. And we see some industries like hospitality that have even higher turnover. An employee might be in the job for a year or 2 years. How do you make the case to employers that this is worth addressing right now when the downstream effects might not happen on their watch? Oh, Kevin, I think you're muted.
Sorry, I think the conversations we have with employers, I think 5 years from now, we're going to look back and say, we should have covered obesity sooner. It leads to so many other chronic conditions. If your employees are thinner, healthier, able to exercise more, they're more engaged. I think there's going to be just a wealth of real world evidence and, many more medicines in the marketplace to address that. All that competitive intensity, with new products coming in is going to drive down net pricing over time, which I think will make the ROI even more attractive as you're building out to years, 3, 4, and 5 year data points, post-launch on the medical cost benefits. And so, we're really talking to employers as they think about turnover. It's really that like prisoner's dilemma. If the whole nation's opted in, you're not worried about it. Everybody's getting the benefit. Right now, that's the challenge that we're working on every day, is when only half or so are opted in. I think you could also see, continued evolution in health benefit design. I think the direct to consumer Lilly Direct landscape is really, was a static, a new signal into a static ecosystem, and kind of the healthcare system responds. And so I think employers are starting to think differently about like fragmentation of design. I think there are some employers we talk to like, hey, I'm a retailer. I have really low margins and I have really high turnover. But if you talk to them and you're like, well, what happens after someone's been at your company for a year? I'm like, oh, well, then our average tenure goes up by like 5 or 6 years. And so could this be something where, it's a benefit where, hey, you vest just like we do on some of our retirement plans, where you vest 12 months in and it becomes a benefit for folks that are looking to kind of step in. And I think, as we launched Lilly Employer Connect, it's very similar to some of the things Robert talked about. Employers really want transparent pricing, and I think that's a unique thing by having, you've got transparent pricing in Medicare, transparent pricing in direct to consumer, and now with Lilly Employer Connect, you're putting transparent pricing out there, $449 for Zepbound QuickPen, and we'll be launching Foundeo at $399 on July 1st. And so that really enables employers to start doing the math that they need, as Robert talked about, understanding predictability. How can they do the modeling, but then design their unique benefit? What's the cost share that works for them? And really having a lot more choice in the partners they've worked with. We've got over 24 independent program administrators we're working with. So I think you're going to continue to see kind of innovation and evolution, even in how we think about healthcare benefits, because I think employers recognize, like, this is a transformational class. Insurance is hard to work when 40% of people have a disease. It doesn't matter what that disease is. And so that's part of the challenge here. So there's a huge opportunity, but it's also, a big challenge. And so that's ripe for just all kinds of different innovation, not just from the medicine, but from the healthcare system, benefit design, et cetera. And so we're excited to jump in and help contribute to that. And our work won't be done until, the vast majority of Americans, whether they're working or Medicare or Medicaid, have access to these medicines that are pretty profound. If someone has a BMI of 40 or above, their life expectancy is about 10 to 15 years less than someone living without obesity. That's an unbelievable number in the country that we live in, with the kind of the healthcare and the resourcing that we have. And so we think a lot about how do we change the game for people. I mean, those are, graduations not seen, daughters not walked down the aisles, grandchildren not held in your arms. So we want to give, like, life back to folks, years, save lives. But it's going to take a lot of innovation because this is a significantly large class. And so I think they're asking all the right questions, and in a vacuum, in a box, it makes a lot of sense. I got low margins and high turnover. I think we just need to find innovative ways to help them get there.
And I would add on that, in terms of the statistic, 1 out of every 4 individuals has class 3 obesity, which is a BMI of greater than 40. That wasn't the case a decade ago. That number is that high class of obesity is expanding by leaps and bounds. When you think of all obesity, the mortality is 8 years sooner than someone who does not have it, and it's the same as smoking. And so we care a lot about smoking. This is the same type of morbidity and mortality we're conferring on our population when we don't treat obesity. When we look at a population level, we're passing the buck in terms of cost, because I'm not going to insure it, but maybe you'll insure it. Maybe then my people will get healthier. I think this is a false narrative, because we're thinking about it, the entire population. You're going to switch out when there are 1 out of 3 individuals who have, or 38%, not even 1 out of 3, who have prediabetes. That's just one condition. Somebody leaves your employment, you're going to get another person who has some type of ailment. And so to start covering that would also be, I would argue, loyalty to the company. You've got somebody who's going to stay and going to give you that ROI, as opposed to not covering the condition that they care about and the disease they care about, and that they would like to live a long, fruitful life. When we think about the 90% of the population. So the American Heart Association came out with a staging system in 2023 called the Cardio-Kidney Metabolic Staging System. And it's stage 0, which means we don't have any disease. 10% of our population falls into that. And stage 1, 2, 3, and 4 are disease states. So stage 1, hypertension, prediabetes, those sorts of things. So 90% of our population, when they've figured out the disease data here, have mild disease, which is blood pressure, prediabetes, and so forth. So one way or another, we're either going to be ensuring a healthier population because we're paying for medications which are effective, or not a healthy population. We'll pass the buck a little bit, but everyone will suffer if we keep on playing hot potato with that.
And I would just add I think, you know, as part of your question, you were talking about employers and, you know, retention. And, you know, I would say it's both recruiting and retention, and trying to get, you know, talent to stay with you, because it's expensive for employee turnover. And what's become more important, as I mentioned earlier, is a good set and offering of benefits that actually play to the needs of the current generations is what actually drives a lot of that loyalty and decision to stay longer. It goes well beyond base pay, like it used to be. That's no longer the number one driver. Benefits is actually overtaken and is now the number one there. And that's because you have things like GLP-1s and other therapies coming, you know, that will be coming forward that they want to be able to participate in. They feel like that's a better benefit to them living healthier, longer lives. And so for us, it's really focusing on the ability to operationalize that, work together with the providers, the plans, the manufacturers, and ultimately allowing that employer and employee, as well as consumers, to have that flexibility in a system that they can have very programmatic, very supportive. It's a defined support and allows them to actually financially afford it and live out a much better life.
All great points. And I know that earlier Dr. Alexander brought up this huge direct-to-consumer market around GLP-1 interventions. And I think that we can even see the popularity of these therapies in the consumer market with the popularity of this webinar. We had so much interest, and people really want to know how they can access these therapies themselves and do it in an affordable way. So 2 questions for all of you. How are direct-to-consumer companies impacting the overall cost of GLP-1 therapies? And how does that affect employers' willingness to cover them if they know that their workforce might be able to get them through an online marketplace?
Yeah, I think that's a great question. I mean, this probably comes up in every conversation we have, whether it's with employer benefit consultants or, you know, employer benefit teams. You know, I think one leader said something really profound. They said, you know, when we think about we're opted out, we want to find a path to opt in. They're like, this is a health equity concern for me. We have some part of our population that can maybe afford to go the self-pay route, you know, and leverage Lilly Direct to get access to Foundeo and Zepbound or NovaCares for their medicines. But there's some folks that can't. And so we really need to, from a health equity standpoint, we want to make sure that everyone has access. I do think that, you know, as more and more medicines come out, you're going to have more and more competition in the class. We know in any new class, you know, when you go from 1 to 2 to 4 to 6 to 8, net pricing is going to go down. And so there will probably continue to be, you know, a robust direct-to-consumer market for quite a while. We still have half of the country, the working country, that has got employer-sponsored insurance that doesn't have access. And so I think it's going to take a while for us to get there to where it becomes on the standard benefit. So I think the direct-to-consumer market is here to stay for a while. I think as that happens and consumers beginning interacting directly with manufacturers in a way they do in so many other parts of their day with purchases they make, I think there's folks, especially, you know, the digital natives that like that. And so I think that's going to be something new that we have to think through and think about. You know, will there be folks they'll compare the cost of self-pay versus what their copay is through their employer, and they may decide, well, maybe I'm just going to use some HSA or HRA or FSA dollars to access this. I don't even want to, you know, kind of mess with the healthcare system. So I think, you know, we're in the early innings of this, and I think when you have disruptive, transformative medication in a really large class that had nothing prior to it, you know, we're going to continue to see kind of the waves of impact and innovation in the system, and how all parts of the system and employers and quite frankly CMS and the federal government kind of respond to this class. And so direct to consumer for sure is here to stay. I think the one thing we would say, because we have both direct to consumer and we're working, with employers, all of these clinical trials were run under the care of a physician, and the medicine on top of like diet and exercise. And so, for folks who want to get the full benefit of the medicine and maybe repeat in the real world the outstanding results that we've seen in the clinic, it's really important that people are doing that under the care of a physician. Robert talked about the wraparound and comprehensive care programs. I think that's why employers are wanting to invest in those, to make sure that the right people get on and then stay on the medication. If they're going to make the investment, they want to make sure that the people's lives are going to be impacted and they're going to get the full return of that as well. But I think we're going to have, for the foreseeable future, I don't think we're putting back in the bottle. I think direct to consumer is here to stay. Obviously, there's a price point. So I don't imagine that people are going to be purchasing oncolytics or immunology drugs on a direct to consumer platform anytime soon. It's just such a small number of folks that would do that. But, it's certainly addressing a need as a manufacturer, of our ability to get people living with this disease to access our medicines. And we're excited about that, but we're working every platform that we have to help grow access to these medicines for patients.
I think an interesting observation to make here is that it is in the best interest of employers and insurance sponsored programs to cover these medications and not require their participants in their programs to go direct to consumer, aside from what we've already discussed around loyalty and so forth, and the switching costs when your program is not covering these medications. In the Bridge program, starting July 1st, CMS is not going to be covering it. There's going to be a wave of coverage that's going to happen. We're trying to avert the inevitable. But when we don't cover these medications and we force people who are desperate to have better health, or to reduce their weight for whatever reason, to go direct to consumer and pay for it out of pocket, we're also denying ourselves and our society the benefits of these medications. And so we're really shooting ourselves in the foot here and not realizing what we're doing. We will continue now to have an expenditure, but not have the adherence, not have the healthcare outcomes. And then we'll have studies published, like the Blue Cross Blue Shield study from several years ago. And there's a newer one that showed it was, people were staying on the medications longer, but not as long as they need to be on the medications to have the health benefits. And so we'll be wasting money going direct to consumer because the healthcare benefits aren't going to be there. They require it requires actual comprehensive obesity care to have those. And why that matters is because 18% going up to 20% of our gross domestic product goes to healthcare spending. That's outrageous. It's more than $5 trillion a year, $5.4 trillion when you look at the CDC website, that's going to healthcare spending in the United States. And the per capita spending from 2000 was $4,500 per person per capita, went up to $10,000 in 2015, and now is at $16,500 in 2025. So our GDP is growing, which is why we're not bankrupting ourselves faster. But if we're just allowing these to be direct to consumer sort of vanity prescriptions, rather than actually using them in the way that they were intended to be used, from the studies, from what we understand, then we're not going to be reaping the benefits of population health and also at a personal level, the personal health. And in fact, we can actually make our health worse. There are medications coming on the market next year, which are going to have bariatric surgery level weight reduction. And those will be very dangerous medications, quite frankly, when they're giving you 25 to 30% sustained weight reduction. And you could buy them direct to consumer, and there are a lot of risks to that. And even at 11% sustained weight loss for Fideo, that's a really big risk to have. When you're going up and down in weight, you're also losing a lot of muscle mass, and that can be prevented when we use these medications in a medical setting that's insured.
Could I add? So I think as we think about it, employer sponsored is great. We work with both government agencies as well as employee sponsored. The direct to consumer is almost a behavioral thing that's part of our society today. And so what we're trying to really look at is how do we bridge or marry the ability to have a flexibility in a program for an employer, for that sole proprietor, all the way down to that individual, owner, where they can actually have a defined benefit that is actually usable across all the different scenarios so that they can feel like they're getting the best cost advantage, most cost effective advantage for, therapies such as this. So as we think about our technology and we continue to bring that platform to bear with the health reimbursement arrangement I mentioned earlier, that will allow us to actually programatize, keep some of those behavioral benefits, that wraparound, so to speak, regardless of where they do their financial purchase, and really continue to drive those incentives around that programmatic aspect. So trying to bring a little bit more of that care wrapper to the direct to consumer so that it's not out there just standalone, and that it actually is an option, just because so many people use that as a purchasing agent these days. So we figure we better tie it in. And so we're figuring out ways that we can do that where the experience overall actually promotes more engagement. And I think as we work together, we're going to figure out how to make that even a better opportunity for employers, employees, and consumers.
Thank you all. I know we only have a few minutes left, but I want to turn to a question in the chat from Irna. She's wondering about the risks, benefits, and side effects for GLP-1 use long-term over 1, 2, 5 years. And just to add a little bit to that question, Dr. Alexander mentions loss of muscle mass. There are also concerns about osteoporosis, nutritional deficiencies. So what side effects are you seeing? And with such a large percentage of the population on these therapies moving into the future, are there concerns at all that we could land ourselves in a larger payment hole when it comes to the side effects or the impacts of the therapies?
So I mentioned, and I was just reading that question myself and hoping we would come to it. It's important to take a step back. I know many out there listening to the webinar are not deep in this environment the way that Robert, Kevin, and I are, and you as well, Alexis. But GLP-1 medications have been in use in one form or another since 2005. They're not new medications that haven't been studied in terms of the side effects and the risks for just a couple of years, and they have a very good safety profile when used responsibly within a medical care setting. They're originally used for type 2 diabetes, which means that they had to be used within the medical care setting that was not direct to consumer at that time, and they're quite safe and very effective medications that are becoming more and more effective as time goes on. As I mentioned, retatrutide and others are going to be coming out next year and the year after. They're giving us 25% plus weight loss. And the concern here around sarcopenic obesity, which is losing muscle mass, is real. And the way to avert that is, again, to have comprehensive obesity care, where you have a program, where I'm chief medical officer. That's one of the programs, and there are many others out there as well, where there's physical activity, where there's correct nutrition, where there's long-term maintenance on the medications. When you're not maintaining your weight long-term and you're cycling up and down, which is what direct-to-consumer has a high risk of doing, that's when muscle mass loss happens, because we know whether it's intensive lifestyle intervention without obesity management medications or with them, that if there's not good nutrition and there's not strength training, that people lose more muscle mass than those who aren't doing this. And there was a study on Saxenda liraglutide called the Escalate study. Anyone who's wants to geek out, they can look at that study, and they can see that when you combine an obesity management medication with physical activity, that people really didn't lose that much muscle mass, and with good nutrition. And when you don't do that, people lose quite a bit of muscle mass. And when you lose weight quickly and then you regain it and you lose it again, you will lose even more muscle mass every single time. And so that is why, from a medical standpoint, I find direct to consumer to be very concerning. And I think there are ways that we can bring this back into the medical care system. I would say the current drug manufacturers of these medications, credit where it's due, have brought down the prices of the medications. They're $5 to $10 a day. We can. It's cost effective to insure. I can make lots of arguments telling you how it's even affordable these days, and at a 2 to 5 year time horizon, not a 10-year time horizon, and that we are also not thinking of multi-morbidity, which means that all of these diseases are connected, and that's why there's a class of medication which treats all of these diseases. It's not magic that suddenly we found a medication and we don't understand how it's treating all these different diseases together. So when we treat one of these diseases, a whole bunch of them get better at the same time. So we're not playing whack-a-mole with all these different diseases. We're treating obesity as the disease of diseases. And so that's what I would say around muscle mass and all of this. It's really responsible treatment in an insured setting within the medical care system.
Thank you to all of our panelists for today, Robert, Kevin, and Dr. Alexander, for being here. Unfortunately, that is all of the time that we have for today. But if any of you on the call would like to register for our upcoming webinars, you can find the links there at the bottom of the chat. Thank you all for joining us, and we hope to see you soon.
Thank you.
Thank you.